Now I call upon Dr. Natasha for her talk on macular mysteries that may be leading to the suspected cases of unexplained functional visual loss.
Good morning to all. So we'll just look at some of the subtle things that we see in the macula that may be missed on a cursory examination, which can give you a clue why the patient is complaining of defective vision and you're not seeing anything. So this patient had vision reduced to 612, few microaneurysms at the macula. It was not involving the fovea, and the OCT also did not show much edema corresponding to the 612 vision. But the fluorescein angiogram gave us the answer. You can see that in the area of the clustering of the microaneurysms, if you can you see that the capillary network is broken there? It's a small tributary vein occlusion that looked like mild diabetic retinopathy. So that is what can happen. Tributary vein occlusions may not produce much of edema, but they will produce severe ischemia with loss of the capillary zone. And if it's at the fovea, for sure the visual acuity will be affected. So that is something you can, if you find something in the fundus and you are not able to explain, a fluorescein angiogram can help you. This patient, you can see, again, it looks fairly, just a few RP changes kind of thing at the fovea, and you can't really explain why there is decrease in vision. If you look very carefully, you can see that there is a neovascularization in the infratemporal area, which means that the patients had an infratemporal branch vein occlusion earlier, which has caused the foveal changes, and that is why the patient has a decrease in visual acuity. This patient underwent sectoral PRP. An old BRVO, you must understand that sometimes they go unnoticed by the patient, and you have to look for telltale signs, especially when you're looking for a difference in visual acuity that you cannot explain. Look at the change in caliber between the superior arcade and the inferior arcade. That can tell you there will be, or some subtle sheathing, some retinal pigment epithelial changes at the fovea. Disc collaterals are a good clue. Of course, neovascularization is like a kind of a definite clue that in that quadrant there was old vein occlusion. If you find pigment clumping like this, always be wary. It need not always be pigment clumping. It can be just a perifoveal whitening. You can see that in the perifoveal area, here there is a whitening. This perifoveal whitening or that pigment clumping is very diagnostic of juxtafoveal telangiectasia. So you can see the leaking juxtafoveal vessels on a fluorescein angiogram, and in the OCT you will get tissue loss, you will get the classical ILM drape sign. And it's very important to recognize this, because although we don't have much treatment for it except in the stage 5 where there is neovascularization, this will change the prognosis of the patient when you find it out. It is prevalent among diabetics, and the OCT is very diagnostic. And if you see this round and red lesion in the fundus, you should not be misled thinking it is normal. Definitely it's a macular hole. So again, sometimes it can be missed on your indirect ophthalmoscopy. You need a 90D or a 78D to recognize it, especially the small ones. It occurs due to tangential traction by the vitreous. The longer the duration, the poorer the vision and the recovery. Smaller the hole, it is the better. Of course, OCT will give you the diagnosis. Here, this is post-macular hole surgery. If you find something wrinkling there, again, it will be very subtle, just a glistening that you see when you're examining the macula, and it is an epiretinal membrane, shiny glistening appearance. Sometimes tortuosity, sometimes straightening of the vessels can occur, depending on which direction the pull is. And long-standing, it can cause cystoid changes, and it is better when it is treated early. Of course, in this stage, it's very easy to recognize. But in the first picture, if you saw, it is more difficult to recognize. This is post-op. We'll just rush through all that. Yeah, again, vitreomacular traction again will occur as just a kind of glistening there, and it can appear as cystoid edema. You may mistake it for cystoid edema unless you do an OCT. And again, you should remember that it is one of the subtypes of diabetic macular edema, which should not be treated by injection. So OCT will give you the answer. And if you see like this, sometimes what will happen is you will see a lot of drusens. Most old people have drusens, and you may think that the visual acuity is not explainable because the drusen is not affecting the fovea. But always drusen means dry AMD. Dry AMD means atrophy. So atrophy will be there in the macula. That could explain why the patient has a decreased visual acuity. So even if they are not involving the fovea as such, do an OCT and that will give you the answer that there is amount of foveal atrophy there that is causing the decrease in vision. And it can slowly progress to geographic atrophy. PCV, when it's subtle, it's a little difficult to recognize. You can see the orange-red lesion there. But here, of course, the exudates are here. Suppose we saw this patient before these exudates came. Sometimes you will miss this orange-red lesion, which is the PCV that is there. That is the polyp. And again, you will get the answer with the ICG and the FFA. Post-operative patients who are complaining of decrease in vision and you're looking at the fovea, it looks clinically normal, take your 90D out, have a look. Are you looking at cystoid macular edema? And again, fluorescein angiogram can help you delineate it. Well, in a diabetic patient who's complaining, diabetic retinopathy he has, who's having CME, you don't know whether it is CSME or it is a pseudophakic CME. The investigation that you can do is a fluorescein angiogram and look for a disc leak. When you have a disc leak, it is a pseudophakic CME. Otherwise, it is a CSME. Why is it important to differentiate? Because you can treat pseudophakic CME with steroids, posterior subtenon or intravitreal, and the other one will require better to be treated by anti-VEGF. Then this patient, 618, left eye, diabetic since 15 years. On the examination, it looks like a severe NPDR. You did an OCT, there is no edema on the OCT. So how do you explain the 618? Again, it is fluorescein angiogram that gives you the answer. There is a lot of disruption of the foveal avascular zone, so it is macular ischemia. So macular ischemia need not produce edema. It will just go on to atrophy later on. So it can be recognized only, of course, now you have the OCTA that will help you. You don't have to do the invasive one, but in a severe NPDR, of course, a wide field angiography is better anyway, so that you don't miss out any peripheral NVE also. Again, CSR sometimes can be written off as a change in refraction because they will produce a hypermetropic change in refraction and the defective vision is not so much. So if you don't look carefully at the fovea, you will miss that blister and you will give a change of glasses and send the patient off. And again, smokestack leak you can see. Chronic CSR is more difficult to find out because it will be just seen as diffuse retinal pigment epithelial changes. Your AF will give you a good idea because AF will show extensive RP atrophy. And this track is very important. This is the AF picture, you can see that there is what you didn't really see on the fundus picture, you can see on the autofluorescence better. And this track, if you see, clinically you may be able to recognize that track, which means that the patients had recurrent attacks of CSR. A foveal blister that can be very easily missed is a PED. And if it's at the fovea, if it is involving the foveal avascular zone, it will definitely cause a decrease in vision. So a good history of a sudden loss in the somewhere along the way, any floaters, any history of injections done somewhere. Many patients will tell you that they've had injections, so then you know that, okay, something was wrong with the retina, or some history of vague near cut, they will say. And a good 90 and 78-day examination. In case of suspicion, do an OCT and a fluorescein angiogram when you want. Beware that macular ischemia can cause decreased vision without edema. Beware of any change in appearance of the fovea. It may be exudates, discoloration, whitening, glistening, change in vessel caliber. In myopes especially, you can do an OCT because myopes, it's very difficult in that tessellated fundus to make out a foveal change. And if you still can't, as an anterior segment surgeon, you can always ask for help from your retinal surgeon. Okay, thank you all for your patient listening.
So that was a wonderful talk. Just one more thing. One thing, that is, we find a lot of RP epitheliitis. Not a lot of, but occasionally we've come across RP epitheliitis in young adults coming with defective vision, macula looking more or less normal with slight stippling. So how do you recognize that also?
Just one. Epitheliitis produces very typical features on the OCT. You will be able to see the hyperreflective outer layer in the OCT.
Thank you, Dr. Natasha.